Hello, and welcome back to another episode of the ASSFN podcast. I'm Danika Paulo, PGY6 neurosurgery resident at Vanderbilt.
I'm Tessa Harland. I am a PGY4 at Albany Medical College.
Today, the topic of discussion is going to be a cordotomy, a pain procedure for cancer-related pain. And to discuss that, we have our guest speaker, Dr. Konstantin Slavin. He is a professor of neurosurgery at the University of Illinois at Chicago, and he is the head of the Stereotactic and Functional Neurosurgery Division. He also holds the titles of President of World Society for Stereotactic and Functional Neurosurgery, President-elect of the International Neuromodulation Society, and past President of the ASSFN. His clinical and research interests include pain procedures such as the cordotomy. So we are very pleased to have him share his expertise and join us on this call today.
Thank you for having me.
Jumping right into the questions, could you tell us a little bit about how you came to be interested in interventional pain procedures?
This is probably a combination of some preference and serendipity. When I was doing my residency in Soviet Union before I came to the United States, the department where I was being trained specialized in functional neurosurgery, among several other things. And the treatment of pain was obviously a big part of that. This was taking place in the late 1980s. So neuromodulation was just taking inroads into the functional neurosurgery, and majority of procedures we were doing back then were related to lesioning, decompression, and other type of interventions for all kinds of functional disorders. So upon arrival in the United States and completing residency here, I did fellowship in Oregon, and by the time I started clinical practice, the destructive lesions almost disappeared. But some expertise was left in the minds and memory of practitioners, and therefore the spirit of at least available interventions for some of the patients, including cordotomy, was preserved. So right now, it is still part of our armamentarium alongside with everything else we do in functional neurosurgery.
Now, cordotomy is not a routine procedure that's commonly done at all institutions, and I imagine many of our listeners may have never seen one. Could you briefly describe the cordotomy procedure?
Well, I'd be happy to. You're absolutely right. These days, majority of neurosurgeons, I would dare say, not only never done it, but never seen it. So they all heard about it. They all studied about it. It is still part of the neurosurgical training and is being asked at the board exam. So people are expected to be aware of certain nuances of cordotomy, even though, just like you noticed, it's rarely done, and the majority of us have never been involved in one. But back in the days, cordotomy was the most commonly done. It was done in thousands in the United States alone. So it became almost completely abandoned because of the introduction of neuromodulation. But before that, the cordotomy was one of several interventions that people were doing on a regular basis. There are several ways to do that, and the cordotomy technique evolved over time. The initial intervention was literally cutting the spinal thalamic tract along the course of the fibers, depending on location of pain. It was done at thoracic level, at cervical level. The direct transection with sharp instruments was replaced with other interventions. There was cryodestruction, there was thermal destruction with direct current, and ultimately radiofrequency became a most commonly used technique. And so this approach with radiofrequency cordotomy was further modified by the making it less invasive. So instead of doing exposure of the spinal cord with laminectomy or hemilaminectomy, people started doing it percutaneously, initially with guidance of myelographic injections, and ultimately with introduction of CT-guided approach. These days, vast majority of cordotomies that are done in the world are performed with transcutaneous, percutaneous approach, usually with CT guidance. There is still a practice of doing open cordotomy with surgical exposure of the spinal cord at the level of lesioning. And there is even more modern technique with endoscopic cordotomy, when the spinal cord can be visualized with an endoscope and a lesion can be done under the endoscopic vision. But the vast majority of interventions are done with CT guidance through percutaneous approach.
Great. And you alluded to this, that there are different levels that you can lesion or target. So which levels do you target for certain body regions affected? Say if the arm was the affected limb or a leg, which levels do you target for those body regions?
Well, the advantage of cordotomy, the techniques that we're using now, is connected to the anatomy of the spinal cord. The pathways within spinal cord are somatotopically organized. So essentially, at any level above the level of pain, you can find the fibers that will be responsible for pain transmission from this particular part of the body. So as long as you are targeting area above the level of pain, you should be able to more or less selectively locate the target for your intervention. So upper thoracic cordotomy would work great for unilateral pain in the trunk or pelvis or the leg on the contralateral part of the body, obviously. But if you have to cover pain arising from brachial plexus involvement in arm, in the neck, then you need to be higher than that, and that's why C1, C2 targeting had become more ubiquitous, because that allows you to catch the entire spinothalamic tract from contralateral part of the body, and by testing location of your tip with electrical stimulation, you can pinpoint the part of the tract that's responsible for this specific body part. So being at C1, C2, you can more or less selectively locate the fibers that are responsible for pain transmission from the arm area, from the chest wall, from the abdomen, pelvis, and the leg, because they follow certain homunculus-like distribution within the spinothalamic tract. So this is something that we use for the more selective intervention as we do the procedure in awake patients, so we can test the path of the needle or location of the needle tip before we make radiofrequency lesion.
Now, classically, they teach that cordotomy is used for cancer pain. In your experience, would you say that that is generally the indication that you are doing cordotomies for?
Yes, and the reason for that is not only the risks associated with intervention, because we really moved away from the destructive procedures because of the associated neurological risks, but also because of the longevity of the procedure. There's certain plasticity within the nervous system, and there is a certain possibility of pain recurrence. If it were to recur, it usually happens more than 6 months from the time of surgery. So the pain relief is usually immediate, but 6 to 12 months after surgery, some patients will experience recurrence of pain. So for patients with advanced stages of cancer, where the life expectancy is relatively short, the destructive surgery presents a unique, a very attractive modality. For people with non-cancer related pain, where life expectancy is significantly longer, the chance of permanent relief with cordotomy becomes lower, even though there are some reports of cordotomy being effective for 20, 30 years after the procedure was done. The general practice, the general notion with cordotomy was that it provides very reliable relief for first 6 to 12 months, and after that, the procedure becomes less effective. So the cancer pain, by virtue of combination of short life expectancy and severity of pain, and the need for immediate relief, becomes a great indication for procedure, particularly since it is something that does not involve any kind of implants, can be done completely under local anesthesia, and provides an immediate relief. So all of these attractive features of cordotomy make it perfect procedure for unilateral cancer pain.
Are there certain types of cancers that you would do this more commonly for, or types of cancers that this procedure is more effective?
That actually has been investigated before, and we generally do not discriminate based on a cancer type, as long as we feel that the unilateral nature of pain will continue due to plexus involvement, due to actual tissue destruction by the tumor neoplastic process. The unilateral pain from any kind of oncological pathology becomes a good indication for the cordotomy. There were some reports focusing on pancreas tumors or mesotheliomas or the gynecological malignancies that invade lumbar or lumbosacral plexus. Those tend to be best indications, not just because they present with strictly unilateral pain, but also because they tend to be associated with a significant amount of pain. The less aggressive cancers, like prostate, for example, or the very disseminated cancers like lung or breast, may not be a good indications for that because of the purely location point of view. So the cordotomy, as I mentioned, is great for unilateral pain. Once the pain becomes bilateral, there's an option of either doing bilateral cordotomy, which has its own set of risks, including possibility of Undine's curse and apnea with a person falling asleep, or something along the line of midline myelotomy, which designed specifically for control of bilateral pain. So cordotomy, being an excellent procedure for unilateral pain, tend to work better for unilateral somatic cancers or plexus invasions.
So you kind of described what a typical patient is that would benefit from a cordotomy with the unilateral cancer pain. In which situations would you recommend cordotomy over other pain procedures, such as intrathecal pain pumps or spinal cord stimulation or cingulotomy?
All procedures that you mentioned definitely have their own place in the algorithm or spectrum of interventions that we offer to cancer pain patients. Now, in all fairness, we do not see many cancer pain patients in neurosurgical practice because majority of oncologists are very comfortable escalating the dose of opioids despite whatever side effects they may produce. So that's probably one of the reasons or main reason why we don't get many referrals for neurosurgical intervention, including cordotomy. But in general, the decision about choosing cordotomy versus, say, intrathecal pump would be the life expectancy of the patient. Anybody whose life expectancy will be more than 6 months, I would strongly recommend considering intrathecal pump, not only because it will have a better chance of long-term pain control all the way to the patient's demise without concern about pain recurrence, but also because the pain will be expected to spread outside this unilateral distribution if the patient were to live longer. So the intrathecal the drug delivery may not be good alternative for a person with very short life expectancy. For associated you need in general anesthesia to implant the pump, for the trialing purposes, for the time that it takes to escalate the dose to reach the therapeutic level. All of the things, do not matter in case of cordotomy because pain relief is immediate. It's pretty much complete, and does not require, concern about medical risks of the patient related to the surgery itself. So for people with short life expectancy, cordotomy makes sense. The cingulotomy is reserved for more diffuse pain when the involvement of multiple body parts at once makes patients bad candidate for the spinal cord focused procedures. So the spinal cord stimulation, at least in my experience, has not been very effective for cancer related pain, not only because of the pattern of pain distribution, but also because of the nature of pain, as the spinal cord stimulation tends to be much more effective for neuropathic pain, and cordotomy seems to be working best for nociceptive pain. So the patients with oncological pain due to cancer involvement itself tend to have tissue injury from the tumor or involvement of the nerves, and those are essentially good candidates for cordotomy.
Now, you had briefly mentioned Ondine's curse, and that's kind of classically the side effect or adverse effect that we learn about with cordotomy. But what are some of the common risks or complications that can occur with this procedure?
Interestingly enough, Ondine's curse doesn't happen in every patient. So it's not like every time you do bilateral cordotomy, you will have loss of ability to breathe or control the diaphragm. So this is more of a concern. It definitely was observed in patients with bilateral cordotomy, and that's why all the research on this topic was initiated back in 1960s. Interestingly enough, the actual cordotomy is remarkably safe. The part of the fact that it's done under local anesthesia, when you have the patient's feedback, including continuous sensory and motor testing, allows you to avoid many complications, because if the patient feels anything out of ordinary, he or she would usually tell you right away as these things happen, and you can always stop the procedure and prevent further worsening of the symptoms. But if you were to consider possibility of risks, they are directly connected to the location of the lesion, because if you put needle in the wrong place and the electrode produces lesion outside the spinal thalamic tract, then yes, you can affect the patient's coordination, you can affect motor function, you can affect the bladder function. All the pathways, as you can imagine, travel very close to each other. But realistically, cordotomy is a remarkably low risk intervention, because even complete loss of nociceptive transmission tends to be remarkably well tolerated by patients, because it does not produce complete numbness in the contralateral part of the body. It produces partial numbness, but the pain fibers tend to be most sensitive to radiofrequency lesioning, and therefore the pain disappears before the body part becomes completely numb.
What role does cordotomy play in your personal practice in the treatment of patients with cancer pain?
It mostly works for me and my team being able to say that we are offering full service of neurosurgical treatment of pain. However, in reality, the cordotomy is done very, very rarely. There are some places in the country that do a handful of cases every year, but those are very few. Majority are probably like us, doing cordotomy once a year or once every other year. Despite the discussion with oncology doctors about availability of treatment and having all necessary equipment, it's very rare for us to get appropriate referrals. And whenever we do get them, the advancements in oncological care obviously extends life expectancy for the patients, and therefore, if we were to consider the choice of intervention, majority of patients, at least that I see, better qualify for intrathecal opioids. The important thing to know, though, that if you really want to offer your service as a neurosurgical expert in treatment of cancer-related pain, I encourage people to have cordotomy within your armamentarium, because there will be patients for whom, for one reason or another, intrathecal drug delivery will not be a good option. And therefore, not having cordotomy as an available alternative obviously limits your choices offered to the patient. So I think cordotomy is something that I would encourage people to learn and be able to do. Whether or not you will actually be doing it in large numbers, that probably depends on the peculiarities of your own practice. But to be able to do this and to have it as an option for your patients, I think that's immensely important.
So if a functional neurosurgeon or general surgeon was interested in treating cancer pain, and as you mentioned, incorporating this procedure into their practice, how could they go about doing that, or trying to learn that procedure, or have that ability?
The actual learning of the procedure is very straightforward. The neurosurgeons, by definition, are well familiar with anatomy of the spinal cord. They are very comfortable with putting the needle into thecal sac, and so there's certain element of familiarity with doing procedure in the CT suite, in the CT scanner suite. But but that's quite easy to overcome. So the patient does not require sedation. Interestingly enough, cordotomy is a remarkably painless procedure. You are destroying the white matter tracts, so they don't hurt when they are being lesioned, which makes it different from, say, trigeminal tractotomy, when you destroy the trigeminal nucleus, and that's very unpleasant and painful for the patient, but although just as effective in providing immediate relief. So cordotomy is well tolerated. The only thing that needs to be anesthetized is the skin and soft tissues, just to advance the needle, and obviously another injection that is required to do the myelogram, because you want to see the outlines of spinal cord when you insert your needle into the thecal sac. The needle reaches the cord, and then the electrode is advanced through the needle, and it's electrode with a slightly curved tip, so you can navigate different locations within the spinal cord in order to come up with an appropriate target. The targeting on cadaveric specimen may be useful just to get kind of acquainted with the tissue resistance as you advance the needle. But the rest is essentially, if you observe one case, you probably will be able to reproduce it in your practice, because you are familiar with radiographic and clinical anatomy, so you will know where the needle needs to be relative to the skull base and C1, C2 interspace on the CT images. And then the rest is just like with any other radiofrequency procedure. You check the impedance of the electrode, you test the electrical stimulation, looking for patient's response in terms of description of paresthesia location. And then once you confirm you're in the right place, you perform the lesion. And the lesion, I usually do 2 lesions for 60 seconds each, but there are different techniques and people do it in different way. And then you ask the patient about disappearance of their pain. Once they confirm that the pain is under control, the electrode and the needle get pulled out, and there's just a Band-Aid on the patient's neck that they go home with. The remarkable simplicity of the procedure is something that makes it even more attractive. But the logistics of neurosurgeon being comfortable, the radiofrequency device being available, the CT scanner suite being able to accommodate you, those are relatively minor nuances, although it requires certain preparation. Every now and then I get requests from my colleagues to let them know when I do it so they can come and observe it. But the unfortunate part with cordotomy is that whenever we get consultation for somebody who needs cordotomy, we usually would do it next day. We would not schedule it in advance a few months later just so we can have the visitors come. So it's very hard to arrange for people to come and see it. And the only people who actually were able to see how we do it are the fellows who are always available to come and watch the surgery. For outside visitors, it's just logistically challenging to do this. So, but having said all this, I know that majority of neurosurgeons just learned it by themselves and been doing it for decades before the spinal cord stimulation came into play and before we had all the pumps. So I know it's not that difficult.
Do you use any kind of neuro monitoring during this procedure?
I do not. I do everything with full patient cooperation. So I ask the patient about what they feel, where they feel it, and that's pretty much it. Adding monitoring will probably make procedure a little bit more complex. It's hard to do physiological monitoring in a awake patient. But if you were to do open cordotomy under general anesthesia, then I would definitely recommend using monitoring, because that will provide extra margin of safety with your manipulation of the spinal cord. The somatosensory potentials are not expected to be affected by cordotomy because you're not touching posterior part of the cord and dorsal columns. The motor work potentials will be expected to remain the same because you're staying away from motor pathways. So you may get some EMG responses from the ipsilateral dermatomes as you manipulate the cord or touch the roots. But in terms of the actual pain relief, here you either using anatomical landmarks when you do open cordotomy, or you use radiographic landmarks when you do CT guided.
Now, you mentioned sort of the history of cordotomy and how it initially started open, progressed to percutaneous, and now is done exclusively under imaging. What is the role now for open cordotomy, and what patients would you consider doing that procedure with the availability of percutaneous?
The history of cordotomy, to some extent, is a history of neurosurgery. It follows all the main steps in terms of the discovery of the intervention, in terms of its gradual acceptance within neurosurgical circles, the advancement in technology, how things are becoming more focused, less invasive, and so forth. And that kind of follows the entire process of neurosurgical innovation. The introduction of less invasive option for cordotomy almost completely eliminated need for open interventions. But the reason people still do it, it's either because they want to have more complete lesioning, which is available with literally mechanical transection of the quadrant of the spinal cord for this, to catch the spinothalamic tract. Or when you do contralateral procedure on somebody who already had cordotomy before, and doing it on the opposite side will significantly increase the risk if you were to do it on upper cervical level. So the effect on the ability to breathe will be an issue. So if you were to do the second side surgery, then open cordotomy at the upper thoracic level will be a great option. And the reason for that is because there's really no good percutaneous option at the upper thoracic level. There's just no easy way to reach anterolateral quadrant of spinal cord with percutaneous approach. So the open surgery is needed, and the most recent paper on open cordotomy probably came about 10 years ago. So people still do it. It came from United Kingdom. So there is obviously experience maintained there. I forgot, honestly, last time I did an open cordotomy. So for me, it's more of a theoretical exercise to discuss all this, as everything we do now is CT guided.
What are your thoughts on which specialties should perform cordotomy procedures, and where do you see the future of this procedure going? How can we make it more effective or more popularized?
The cordotomy, there's really not much discussion here. The cordotomy is exclusively a neurosurgical intervention, and I would imagine that any neurosurgeon who would be interested in doing it will be one way or another connected to the functional neurosurgery subspecialty. I just cannot see my vascular or neurotrauma colleagues or even spinal neurosurgeons to be particularly excited about cutting somebody's spinal cord to control their pain. So I feel that the functional neurosurgeons are probably the best specialists to do that. I mean, I don't see anything wrong with people outside of functional neurosurgery field to do this, because back in the day, pretty much any neurosurgeon was doing cordotomy just because of sheer number of the interventions were needed nationwide. But now the fact that we specialize and do it in more focused fashion, I think gives us a little bit more expertise and interest and maybe enthusiasm in doing so. Our interventional pain colleagues from non-neurosurgical backgrounds are generally reluctant to touch a spinal cord, and we do not encourage them to embark on that target because it's not just they don't have skills. It's more of concern about the complications and how to mitigate them if you are not a neurosurgeon. Because if something happens and there's a hemorrhage or there's an infection or there's any other injury that will require formal neurosurgical intervention, then non-neurosurgeons may not necessarily be comfortable doing that. And in general, the majority of interventional pain specialists probably would not want to stick a needle directly into the spinal cord, or at least intentionally. So so I think there's still very much something for us as neurosurgeons to own and promote.
And as you mentioned earlier, you said referrals for this procedure can often come pretty late in the patient's disease course. But you also said that you really only consider this procedure for people who have a life expectancy of less than 6 months. So do you think that an effort should be made to make earlier referrals for this procedure?
You see, the reason the referrals come late is not because of the doctor's reluctance to do this, but because the pain tends to be more prominent at the later stages of cancer involvement. The unfortunate statistics is that the majority of patients with terminal cancer suffer from severe pain. The in absence of high dose opioids, the pain becomes the main reason for the impaired quality of life and the disability that the tumors cause. So for us to offer our services for patients with cancer-related pain makes perfect sense. To do it earlier would be a great option if the pain is severe enough to justify it. But the correlation between severity of pain and the stage of disease is such that we try to intervene as soon as we are consulted. And then if at that time the patient still has a long life expectancy, then we proceed with intrathecal drug treatment. If the patients have short life expectancy, then or cannot have pump for whatever reason, then destructive interventions obviously become more attractive.
Thank you very much for your insights. Is there anything else you'd want to share with our listeners about cordotomy or other pain procedures?
The one thing I probably would want to say that, if you consider yourself a full spectrum functional neurosurgeon or neurosurgeon who treats chronic pain, the knowledge of cordotomy technique is important. For trainees, I feel that mastering or at least becoming more familiar with cordotomy is important because it really makes your referral pattern more complete. If the oncology doctors know that you as a neurosurgical pain specialist are able to do this, they will not hesitate to send you patients who in their mind are not candidates for intrathecal drug treatment. So you suddenly have something that you can offer patients who are otherwise hopeless. And the remarkable pain relief that cordotomy or midline myelotomy or even trigeminal tractotomy afford to the patient is so impressive that just by doing it once, you will immediately increase the number of referrals coming to you with that may or may not qualify for doing this again. So I think it's remarkably rewarding intervention for a physician because nothing is giving you better moral reward than to see your patient becoming pain-free right there on the table. I mean, this may be compared to maybe some trigeminal neuralgia surgery when patients wake up from operation without pain, or some extreme cases of decompressing the nerve somewhere in extremity. Everything else takes time. There's certain ramping up effect for our interventions, particularly when it comes to neuromodulation. Here, the effect is immediate. The pain relief is almost always complete. And the patient who is debilitated by pain suddenly can move and function and enjoy life again. And to see the smile is probably definitely, for me, makes having the skill worth it.
Yeah, absolutely. If you can have that kind of an impact on your patients' lives, I think that's what we all strive for. Well, thank you very much for joining us. It was a pleasure to have you for this episode. And thank you to all of our listeners for joining, and stay tuned for another episode coming up.
Thank you very much for having me.